Okay, we're going to move along to the next portion of the program. First is Whitney Hodgman. She is with Home Services for McLaren Greater Lansing, and the topic is going to be Home Care 101. So I'll turn this over to Whitney. Yep. Yeah, they're recording it, so that's what it is.
Okay. Good afternoon. Again, my name is Whitney. I am with McLaren Home Care Group, and I market both home care and hospice for our company. I am a nurse, and I have had experience with patients in both a hospital setting and in a skilled nursing facility, so I may talk a little bit about that as I'm going through my presentation. And I've been with McLaren for a couple of years now. So I just want to give you a brief overview of what home care looks like. Some of you may have written an order before for home care, maybe evaluate and treat. And I want to kind of show you what that looks like with our patients, some of the rules and regulations that we have to follow when we're going into the home. And feel free to ask questions as we go along. So McLaren, we provide clinically excellent, compassionate care to our patients in their home. And home care can be for anybody, people of all ages who have health problems and they want to stay home or have to stay at home, but they want to remain independent. And we go in there and we provide care that can't be effectively provided by their family members or that they can't do themselves. So an admission to home care, we need a physician's order for that. So it can only be made under the direction of a physician. And it's based on the patient's identified care needs, their homebound status, and the type of services that they are requiring. We have a whole home care team that we can call on to provide that care for our patients. We have registered nurses, and we have physical and occupational therapists. To start home care, to open it, we need either a registered nurse or a physical therapist to do that. So we need one of those two disciplines to go into the home. We also have speech therapists, we have home health aides, we have medical social workers, and we also have dietitians. So I'm going to talk about the role of the nurse and the home health aide, and then Dan Gillette will talk about the therapy, the occupational and physical therapists, and what they do in the home. Our nurse will go in and she will develop and initiate that plan of care for that patient and then get the physician to sign off on that plan of care to agree to that. Some of the services that she will do is he or she will go in and they will assess the patient. We will do some monitoring with that patient while they're on our service. We will provide some technical medical treatment, especially wound care is a big thing that we do in home care. Administer medications by injection. Again, if patients are on just oral medications, we will go through those with them and make sure they're taking what they need, but we're going in there when they need injections or IVs, things like that. Patient and family education, this should probably be at the beginning, at the top of the list. That's what we do every time we go in on that visit is we're educating the family or the patient on the disease process, on their medications, on their treatment, explaining any changes that they may see, and then also talking to the physician and informing them of those changes and getting different orders as we go along. We are going to identify and we're going to plan for that patient's discharge. Just like in the hospital, when we start planning the discharge when the patient comes into the hospital, or in a nursing home when we're planning their discharge from rehab when they first enter that rehab center, we're planning that patient discharge when we go into the door the first time. Our goal is to work with them until they are either self-sufficient or the family is comfortable and can handle the care for the patient. We also supervise the home health aides. So the home health aide is responsible for taking care of the bathing, the toileting, the ambulation, the meal prep. There's a misconception. I talk to a lot of families, and they'll tell me, my mom needs home care because she needs someone in her home every day from 5 to 7 to make sure that she's eating and to help her bathe. That's not what we do. That would be private duty. That is not covered under insurance. That would be a private duty agency where they would have to pay privately, and that would not require a physician's order. A lot of times those people don't need nurses or therapists really in the home. That family just wants another set of eyes in that home making sure mom is okay as she goes about her day. So our home health aides will go out 1 to 2 times a week and probably really work with bathing, do that range of motion exercises, and they're usually working in conjunction, obviously, with the nurse or with therapy, because if someone needs a home health aide for some of these things, they probably need occupational and physical therapy also. So when is home care appropriate? We see patients that are recovering from illness, accident, or surgery. So we get a lot of our referrals coming right out of the hospital, recently discharged from the hospital or nursing home. And think about those discharges. I know when I worked in the hospital, as soon as someone mentioned discharge to that patient, they were packing their bags and they were calling their family and they were ready to go. So now when I sat down with them and tried to go through all the discharge instructions, I don't think they were paying much attention at that point. They were just thinking about, where's my daughter, because I'm ready to go home now. So we're going to be working very closely with them when they come out of the hospital or from the nursing home. When they're in need of assessment or screening to manage their medical conditions, again, the treatment of wounds is another big one that we do. Administering and monitoring the medications. When there's a change in health status, so when there's a new diagnosis, when there's a change, when that's a CHF patient who's starting to have, they're starting to retain water, they're starting to have more issues, they're having trouble breathing, a COPD patient who is having shortness of breath more often, now at rest, it used to be just with exercise. So any kind of change, a new diabetic patient, those are some of the patients that we see. And then someone who's frequently falling, they could probably use some therapy at that point. Maybe not a nurse, but maybe they need physical and occupational therapy. And Dan can talk about some of our specialized programs that go along with that issue. We have to follow, or we do follow Medicare and Medicaid certified the guidelines. So a patient for home care needs to be homebound. And what does that look like? So a homebound patient has a normal inability to leave home. So it's a taxing effort for them to leave their home. They can go to church, they can go to funerals and weddings, they can go, go get their hair done, but it is a taxing effort to do that. Think about the patient, like a COPD patient who's going to the doctor. It takes them, 10 minutes to get from the car to the doctor's office because they've stopped twice to kind of lean over and do that, catch their breath because it's such an effort to get to that doctor's office. Someone who can't leave the home except with the aid of supportive devices. So again, think about a surgical patient, someone who just had hip or knee, and they now have a walker or a wheelchair or a cane, something they didn't have before. So that could be a homebound patient, and they need special transportation. Just because a patient doesn't have a car doesn't mean they're homebound, because they might have other ways to get out. But if they require special transportation and they have supportive devices, they could be considered homebound. Someone who needs the assistance of another person. They're always calling on their family to help get them out to the car, into the building, wherever they're going. Someone where leaving home is medically contraindicated, so again, a post-op patient. And again, that leaving home would require a taxing effort. And again, homebound does not mean bedbound. The people that we see that are considered homebound are, again, they're up and about and doing things throughout their day, but it's just, again, it's difficult for them to do that. And a home, so we go into their home. A home can be wherever they are living. It could be, a relative's home. It could be a shelter. It could be a senior living apartment. It could be an assisted living apartment. So that would be considered their home, and that's where we go and provide the services for them. We have some specialty programs. Home care offers, again, besides just going in and as a nurse and doing an assessment, we have some specialty programs that our specially trained clinicians can provide. So the first three of these are OTPT driven, so I'll just list them and Dan can talk about them. One is maximum mobility, and then we have a senior site program and a joint express program. A couple other programs we have a palliative program, and that's, you may be hearing more and more about palliative care, and that is kind of a bridge between home care and hospice. So it's someone who has like a CHF patient or cancer patient. They may be, they're still seeking treatment, which again, if they're in hospice, they're not seeking curative treatment, but this patient would be seeking curative treatment. They are homebound. They have to have that guideline of being homebound, and we start talking to them about, things like advanced directives, kind of how this disease is going to progress as it goes along, what they can expect, what they want for their plan of care. So we do have that palliative care program. And the other program we have chronic care programs for our CHF and COPD patients. Again, a big thing with home care is we're trying to prevent hospital readmissions. So these programs, they include some disease protocols specific to that disease that our nurses and therapists follow. We even have a special nutritional program now where we offer for patients, say the patient who has wounds that are very slow to heal, a patient with a failure to thrive who has lost some weight. We will go in and assess their nutritional needs, and we can offer them some supplements and then some coupons for supplements ongoing, and we will go in each time and evaluate their nutritional status and see how they're doing, because we know wounds will heal quicker when they are getting sufficient nutrition and higher protein. So that's a program that we do, a specialized program under our chronic care umbrella. The other one that we have is we do telehealth monitoring, and I will talk about that in a little bit more detail later. We do a lot of patient education. We have big magnets, and we talk about red, green, and yellow zones for their disease, and if they notice these symptoms, it means they're in the yellow zone, and they should be calling us. If they're in the red zone, they should be calling their doctor or calling 911. So we do a lot of education. We have booklets for them. We teach them and the family, this is how the disease looks, this is normal, this is abnormal, this is when you should call someone and get some help. So that's that. Chronic care management, it says the home is where chronic disease management can succeed or fail. So a patient can undo a month's work of expensive intensive care by just going home and going about their normal routines. We've seen that. I've talked to people in the nursing homes. Again, they're so ready to go home, they don't think they need us. Or they don't want us to come in because they don't want to be a bother, or they don't want us to see their home. I mean, there are a lot of reasons why people may not want us to come into the home, but we could, if we convince them to let us come in. A lot of times what I tell them is, you think about all this therapy you've done here for the last 30 days. If you go home and just go back to your routine of, sitting in a chair and watching TV and, going about your daily routine, you're going to lose all of that progress you just made. So again, what we will do is we will go in and we can help continue that progress, and they can even make more progress once they get home. And at that point, they will usually let us come in and do that. Again, or someone who's had some issues, like nursing issues. Sometimes that's a little bit easier to come in and convince them that we should come in if they're having some, again, if they had a CHF exacerbation and it ended them in the hospital and then nursing home, they don't want that to happen again. So if they let us come out and do our nursing care, maybe we can prevent that from happening again for them. Or we can catch it sooner, so we can get it taken care of. Maybe get some Lasix ordered, add more, get something else going for them, so it doesn't end up into another emergent situation where they're going to the hospital. We also offer infusion therapy. So again, we can go in and we can do, they can receive medications and fluids right in their home. And here's a list of some of the different services that we offer. So we can do tube feedings, steroid therapy, antibiotic therapy, hydration, pain management, and immunotherapy right in the home, which again, they like that. So the other services that we use to help, again, prevent those rehospitalizations, one is Lifeline. We offer our patients that button, help by phone, I can't get up kind of button. We offer that to our home care patients for 60 days as part of that plan of care. We found that those patients, and again, when you think about someone who's a fall risk, a little unsteady on their feet, that's probably about 95% of our patients coming out of the hospital or nursing home, if they've had any kind of length of stay at all. That nice button helps them. They can press that button if they fall, and they can get help right away. Because I know as a nurse, I remember seeing a few different patients who ended up on the floor for hours and hours, and then looked at those, saw those sores and wounds that were very slow to heal, and now they're in the nursing home for 90 days. So that is one service that we offer to our patients. The other one is CardioCom, and I have that. I can show you what it looks like. So this is our CardioCom or telehealth machine. This is, again, for our chronic care patients. This little machine goes in their home. It's wireless, and we can hook up blood pressure cuff, a pulse ox, and also a scale. So every day they get up and they get on the scale and get their weight. Again, for a CHF patient, that's so important. We can get their blood pressure, and then we can also get their pulse ox. Again, for a COPD patient, very important. All of that data is sent to a central location where a nurse is watching it, and if she sees anything out of the ordinary, she's calling the patient and asking them if it's a COPD patient, okay, I see your pulse ox is a little low. You know, how are you feeling? What were you doing when you did that? Are you feeling short of breath? And have a little conversation with them. Blood pressure's high. Did you take your blood pressure medication this morning? Did you remember to do that? If the weight's a little bit high, are you noticing some swelling in your legs? Or, you know, try to kind of do a little bit of triage with the patient to try to figure out what's going on. If something's out of the ordinary and they're concerned, they call us, and we will go out and see that patient for an unscheduled visit. We have, since we started this program, we have been out to see patients and been able to, again, call the physician and get an order for Lasix or whatever it is that we needed to do, and maybe we've prevented that emergent situation where now they're calling 911 and they're going back into the hospital. In fact, our rehospitalization rates have gone down 4 percentage points on our cardiac patients since we started using the telehealth in their home. And again, these are for patients who are on our home care. So that is a kind of just a brief overview of home care, kind of what it looks like, what we do more from the nursing and home health aid side of things. Anyone have any questions at all about that? Yes?
How many patients does each nurse have?
You know, that varies because, again, when they're doing a start of care can take an hour, 2 hours to sit there and really go through everything with a patient. So I would say, is it about 7 or so, Dan, would you say, on a busy day, like 4 to 6 a day? So, and I've seen nurses who've only had 3 because, again, if they have those starts of care, they know it's going to take longer. And it depends on geography, too, because, you know, they're in their car driving around to see all these patients. So.
How long has CardioCom been?
We've had this program for almost a year now. And we had a different telehealth before. The nice thing about this one, too, is if, say, the patient forgets to get on the scale and do all of this, they're going to be getting a call in a couple hours from that nurse and saying, you know, Mr. Smith, I don't have your weight and your blood pressure yet. Did you forget to do that? So they will also get a reminder. So that's how closely we're monitoring them. Yes?
Do you guys provide this service as an infusion center for the homebound patient then? Bringing, like, for example, vancomycin to their house?
It goes to their home. It goes, yes, we provide it in the home. So we provide the IV, the pull, the pump, whatever it is, and then, and we do that right in their home. Anything else?
But a lot of patients that don't have vehicles and they take the bus and are non-compliant because of that. Is that a good enough reason?
No, just because they hate the bus, no. Again, if it's a very taxing effort, and let's say they hate the bus because it takes them a half an hour to get to the bus stop because they're so ill and it's such an effort, that might be considered homebound. But just because you hate the bus, that doesn't count.
In order, home care, does the physician have to put exactly what they want you to do, or do you guys kind of do your initial assessment?
We've seen, and again, I work a lot with the nursing homes, and usually there I will get the order that says, you know, discharge home with McLaren Homecare, PTOT, nursing, home health aides, social work. Sometimes I think we get, you know, orders from the physicians, especially maybe coming from an office or something that just says, you know, evaluate and treat, and then we're going to have to call and tell them what we need. We always tell people, when in doubt, we'll go out. So it's not up to you to decide if they're homebound or not. That's for us to determine once we either talk to them on the phone or make that first visit. And then we can determine whether they're really homebound. I mean, again, if it's because they hate the bus, probably not homebound. But again, if you're a little iffy and you're not quite sure if they really are homebound or not, we can figure that out. For them. I've seen times where they're not. You know, we had a patient who, or a referral from a physician, but when we went out there to see her, she's going to church functions 4 nights a week and running around and doing her grocery shopping and everything, and she didn't want to give any of that up. She didn't need to. Well, that's not homebound. She could go get outpatient therapy or something at that point if she needed it. Any other questions? No, we need to get a recertification. Dan, remind me of that. It's 60 days.
And then, do their benefits ever run out with insurance, or will it always be covered so long
As long as they meet, yeah, then they will be covered. You had one?
There's multiple, like, home cares and infusion, like,
Mm-hmm.
in our own community.
Mm-hmm.
Can the physician decide which one they want? Like, so, for example, like Sparrow, I feel like needs to be home care, automatically goes to
Sparrow, right.
I can request their
You can. You can. And again, I think it works differently. And again, if you're in a physician office, obviously you're choosing that on your own. Sometimes in the hospital, I think you can do that. I don't, sometimes case managers get involved too. So you'll want to probably just make sure that kind of follows through with whoever you request. In the nursing home, again, it's really kind of, it's driven by the social workers in the nursing home. The physicians will say, yeah, I think this patient needs home care. A lot of the times they're not picking that. It's the social worker that's choosing that, together with the family, talking with the family. Right, and some don't offer infusion. And, we have home care and hospice, both, so we can follow a patient all the way through maybe that disease process, where some are only home care or some are only hospice. So I think we all have a little bit different niche, and we each have something different to offer. But yeah, and again, coming out of the McLaren, Greater Lansing, we like to see those patients coming to our home care. So unless a patient is current, meaning they are still on the books with another agency, and we can even see them then, they just need to let that other agency know that they want to discontinue services, and then we can pick them up. Anything else? Yes?
Can you use this CardioCom exclusively, or does it have to be like packaged in with other home health care? Let's just say a new CHF patient who's totally capable of taking care of themselves in and out of their home, but maybe that first month or two out of the hospital you want CardioCom. Can you do just that?
With us, it needs to be we need to have them under a home care service. So again, are they homebound?
No.
Okay, then they're not going to be under our home care service. Because that's usually the biggest trigger. Are they homebound or not?
It's not like we're going to send them, if we want to wait every day and certain blood pressure to be monitored
Right.
every single day, well, we're not going to have them come to the office every single day.
Right,
So, but that would be more of a private thing for them to consider.
right.
We can't get.
We can't, no, because in fact, we don't, McLaren, we are picking up the cost of this because we know it's so important to our patients, and we've seen the results of that with that lowered rehospitalization. We as a company are just picking up the cost of these. So again, they need to be under our service to have that as part of their plan of care. And this is, the other thing, so this is an order from the physician that they want CardioCom, and then the physician gets the results of that on a weekly or biweekly basis. So, again, you'd be getting a fax with those results of each patient, so you would be able to see that also.